We are live, sir. Sir, we are live.
Yeah. Good afternoon, everybody. On behalf of MCure Pharmaceuticals, this is Balaji, Head of Global HIV/AIDS Initiatives, inviting you to this webinar. This has been a tradition with us that after every IAS conference, we host a webinar on the latest updates from IAS, and we have the pleasure of having eminent speakers and panelists this time uh, who require no introduction, but it's my privilege to introduce Dr. Kumaraswamy, Chief and Director of VHS Infectious Diseases Medical Center and Director, Chennai Antiretrovirals Research and Treatment, Clinical Research Site. He will be presenting the HIV treatment updates, and followed by we have panelists, Dr. Ishwar Gilada, consultant in HIV and studies from the Unison Medicare Research Center and president of the AIDS Society of India, and he's also on the governing council member of the International AIDS Society. And joining him on the panel is Dr. Vijay Yaldandi, a clinical professor of medicine and surgery. He's been with the University of Illinois, and now he's a project director at Share India. So with this introductory words, I hand over to Dr. Kumaraswamy for the first part of today's webinar. Over to you, Dr. Kumar.
Good evening, everyone. Thank you, Dr. Balaji and the organizers for inviting me to do this. I'm going to quickly share my screen. Can you see my slides?
Yeah, fine. Go ahead.
And it's moving, right? Right. So wherever you are located, greetings from Chennai. So what I'm going to speak to you today is I have two parts in my presentations. The first part is on the new WHO guidelines, which was being launched at this International AIDS Society Conference 2025 at Kigali. So I'll be giving a little updates, which might be immediately useful for your clinical practice, and which will be followed by some of the key updates. The conference went over for almost 4 days. So I cannot cover everything what's been discussed. So some of the key aspects from the antiretroviral therapeutics, which might make to our guidelines in future, might be in the next 2 years or so that you'll be primed, equipped, and to those knowledge, and when it has been available, to your clinical practice. With this brief, I just want to go into my next slide. That is the presentations. What I'm going to cover is, in this IAS, there were presentations from the guidelines, which was on the day one. There were a lot of discussions on oral presentation, invited talks, and posters on some of the newer treatment logistics, and as well as modalities, and as well as the new drugs. And some of them are very much in the pipeline. There were discussions on newer biomedical HIV preventions. There were discussions on some of the new data on some of the comorbidities, that is, complications following HIV treatments or HIV disease, and of course on co-infections and STIs. And just for one of times in this, I'll be just covering the first two, and if time permits, I'm a little touch upon biomedical HIV prevention. Then I leave to the panelists to discuss some of the implementation issues. To start with the HIV guidelines, these guidelines have been updated every 2 to 3 years. The last guideline, the one what we have been using, is the one we developed in the year 2021, with some updates on some of the newer studies. Since then, the guidelines were not revised because we didn't have much newer data or newer drugs for resource-limited settings. But in the last 3-4 years, there are a lot of good studies have been done. And some of those updates, which are given in the earlier guideline, need to be a little updated or amended, not removed, it's amended, So that's what is being done in this. If you look into these slides, I have put one of those previous recommendations from the earlier 2021, which we have been currently using as part of a national program or part of your routine clinical private practice. The new changes which are on the right side, you can see these new regulations, which I'll be going through, with some evidence why this was being updated over in this particular conference. As you all know that we have these first line therapy, so which is these TLD, tenofovir, lemivudine, or emtricitabine deltagrel are preferred. Now, became part of the guideline and which has been disseminated everywhere, and it's been is a great success, across the globe in a record time. And also, we should laud our Indian generic manufacturers. Thanks to them, 92% of all those people living with HIV across the globe were able to have access to these TLD regimen, and they went on that, and they've all been doing well and had a good viral suppression. Now, having said this, as many of you are in the clinical practice, we all know that tenofovir can produce renal dysfunction, which has been earlier shown by our group some years back, and we have been looking at how newer drugs can be brought or amended to this. And this was soon followed by on a large cohort study from our Asian region. And we also compared this with an African cohorts and Latin American. We found that Asians are prone to develop more renal dysfunction as compared to Africa and Latin America, which has also been shown. Following these WHO guidelines, also amended at that time to implement the creatinine monitoring 2 to 4 weeks after initiating on a TLD regimen, then at the 6th month, 12th month, and annually, which many of you have already been implemented in your practice, either in the program or in your routine clinical practice. So again, even if you implement this, you're bound to see this over a period of time. So how we can, solve this particular renal dysfunction. And also, tenofovir can also produce BMD, bone mineral density loss, and as a result, patients are prone to develop fractures and things like that. So the only other option is, but it's on the other hand, is a potent drug. It can be given in hepatitis B co-infections. It can be safer in pregnancy, and it can be very easily put as a single tablet as an FTC. So the option being, to preserve the same function is the pro-drug of tenofovir is called TAF, which was in the earlier guideline. If you look into that very carefully, there will be a small bullet point will be there. It's there in some special population. What we have indicated that was people with the kidney disease or people, menopausal women, and some of those elderly, just put in the very small, but it's not been given a lot of prominence by the program, but used a lot in the private practice. So this particular guideline, 2025 now, the update very clearly shows TAF is also being brought as a preferred first line, not alternate anymore. Either tenofovir or TAF, you can choose. If you feel that the patient already have a renal dysfunction or have a risk to develop like diabetes or elderly, postmenopausal women, in all those, you can start on TAF. And today, data also shows TAF is also safer with the TB medications. Initially, there was some signals on that. Now it is still, you can use this either with the lemivudine or emtricitabine and dolutegravir. Currently, this fixed dose combination is available in India as TAF, emtricitabine, and DTG. Like a TLD, it's been available, so it's been recommended. And why this recommendation is again done is it's very important because we have been following large number on PDF. And why, on looking at that, you may ask a question, why should I change them to this TAF-containing therapy? So if you look into this cartoon, if you look into the drug called tenofovir, which never gets absorbed in genome tract, it gets excreted. But on the other hand, tenofovir diproxyl fumarate, which you have been using already in your clinical practice with 300 milligrams, when it has been combined with lemivudine and dolutegravir, when it's absorbed, it has got a shorter plasma half-life, where you can see this major part of the drug gets excreted to renal, tubular, cellular function and causing renal disease. Only a small proportion of them go to the target site to contain HIV replication. If you look into those, the pro-drug, when you develop this molecule, at a certain stage where if you stop, it's called the pro-drug, which is also called tenofovir alafenamide, we call TAF, as 25 milligram. And even in a smaller dose, when it is being given in combination with other medications, where very a small proportion of them, gets excreted to the renal, tubular, cellular function, causing renal disease, where larger chunk of the drug goes to the target sites. And again, a smaller strength is being needed. Now, this is another reason that this drug will be less toxic. I'm not saying that zero toxic, will be less toxic to the renal system as compared to tenofovir. Also, tenofovir can also produce BMD loss through another different mechanism, where TOF has got a similar mechanism, but it has been very minimal. And for this reason, in this guideline, it's been recommended, and I hope it will be implemented as soon as possible, across the lower and middle income countries. In the research settings, it's already been implemented. It's part of the DHS guideline, European guideline, and British HIV guidelines. But now we waited for several other data, particularly in pregnancy and as well as in TB. Now we have some good signals, so hence it's been moved forward and also been available as a FTC and also generically been available. Use it in your practice. And if they're already on TLD, also you can change them easily, with the TAF-containing therapy. And one other recommendation for this particular renal dysfunction to prevent diseases is the usage of two-drug therapy. Many of you have already been using this in your clinical practice, this particular drug which has been approved as a combination of lamivudine and dolutegravir as an innovator as Dovato. In India, it's available as Twinact. We've already been using this. In these guidelines, after reviewing tons of implementation science data from research settings as well as from clinical trials, it's been strongly recommended someone who is already on TLD or TAF-containing therapy, if they're virologically suppressed, especially if they're on the first-line therapy, where you can change them after 6 months. When they're on the earlier therapy, if they're suppressed, you can change them to this two-drug therapy of the 3TC, DTG. So there are implementation science studies have been done to show that it maintains a virological suppression. And also, once it has been moved to this particular regimen, we also recommend, if you have access to do viral load, you do a repeat within another 2 to 3 months' time. So this is very, very important because if they have any earlier initial failure, then probably you'll be able to know whether they have already been causing any viremia or not, so that you can look into other actions like in either adherence or whether they're developing failure or not. But very importantly, this combination should not be recommended if they are co-infected with hepatitis B. As you all know that today, someone who's co-infected with hepatitis B, we don't need to add any more drug. Tenofovir acts very well, TAF acts very well. So along with the lamivudine. So someone who is hepatitis B co-infected, so if you have to give this particular regimen, then you also have to bring another one, hepatitis B medications in the form of entecavir. So, but if they don't have a renal toxicity, then better to continue the same TLD or TAF in HIV and hepatitis B co-infected people. Hence, before we switch to this, make sure that they should have a hepatitis B screening. If they're not, you can do it. It's currently it's an inexpensive. You should do it. But also, it's very important today. We use TLD and TAF, FTC, DTG along with the rifampicin-containing therapy. But when you are giving this two-drug therapy, make sure that they are virologically stable and also they do not have active TB. When someone who have rifampicin, this regimen is not recommended because we don't have good data on doubling the dosage of these two drugs along with the dolutegravir. Hence, it is not recommended. Once the TB therapy is completed, if they are virologically suppressed, then you can move this. So this is another recommendation, which some of you are already doing. This is something, this drug has also been available in India and many resource-limited settings now through generic manufacturers. So it's time that make sure that our patients are not developing any renal toxicity or bone toxicity before that you can substitute to this medication. I won't use the word substitute to this medication till it will be a first line and make sure that they are virologically suppressed. The other recommendation is particularly on the second line. So again, it is not new. Many of you have already been implemented, but it's not part of the guideline yet. So this again, someone who had failed TLE or earlier regimens. So what he did was you have changed them to AZT-containing therapy, and as well as the third drug is either a protease inhibitor like atazanavir or lopinavir or a dolutegravir. It's something what you have done that. So as you all know that this AZT is highly toxic. That's the reason that we moved this out of the first line earlier. But when you are moving to the second line, there are studies have shown there is a poor adherence, and as well as there are more chances of virological failure. So there were questions on can we recycle this tenofovir, because small scale study shows that even if they fail with the resistance mutations, it still have some activity when it's combined with other drugs, potent drugs like dolutegravir, and also along with lamivudine or emtricitabine. One such study, which is not new, not presented here, it has been a couple of years back now, been published, called Nadia study, which was done in sub-Saharan Africa. So what they did is on patients who had failed TLE with efavirenz, So they randomized to two groups. One group, they put them on these guideline drug or AZT3DC and dolutegravir. Another group went on recycling tenofovir. Also, there is another arm where they're also been randomized to darunavir in both arms. They followed them over a period of time. At week 96, they found that they also did a lot of subgroup analysis. Just for this particular guideline change, I'm showing only that particular slide, stating that patients who had even tenofovir resistance from the first-line failure of TLE, when they changed them, recycles to tenofovir, you can see this in the second bar, where they still have higher activity than AZT, where they never had AZT mutation. And again, when they did sub-analysis, they found that AZT had a poor adherence because of nausea, vomiting, and anemia. So this tenofovir still worked. And so this was one study. With one study, always you won't make a recommendation. So WHO was waiting for other large-scale studies, which was well supported by our one study, which I was involved in this and I presented last year at the World AIDS Conference, and now we published it. It's a study called DEF study, which is a very large global trial. We carried out in 12 different countries across different continents. So what we did was patients who have been failing efavirenz-containing therapy, we randomized to 3 different groups. One group, we put them on 2 NRTIs. That is, if they are on tenofovir, we change them to AZT-containing therapy. And another group, and along with that, we put them on the PI instead of atazanavir. We put them on darunavir 800, 100 milligram ritonavir once daily. Also, if they have resistance testing available, so you can recycle tenofovir, that we did that. And we compared them with the 2 other test arms. One is we recycled tenofovir and put them on BTG to answer the critical question for WHO. And also we added a newer regimen, that is darunavir along with the dolutegravir. So we presented the 48-week data last year, and this year we published the 96-week data. And what we found in that is, so for this particular guideline change, there are 2 things came out of this particular DEF study. It got just published in Clinical Infectious Diseases. What we found in that is, as compared to the standard of care, there is 2 NRTIs and a boosted PI, recycling tenofovir when they have first-line failure, along with the dolutegravir, which is non-inferior at week 96. And also we found that the newer regimen of darunavir and dolutegravir was found a little superior as compared to other things. And also when we compared 2 NRTIs with a boosted darunavir and recycling TLD, where we found that which has been non-inferior. So you just got a good evidence to the earlier Nadia study to state that, so where you can recycle. So someone who fails TLE, you can change them to TLD, which some of you have already done, but in the national program still you might be using AZT. Now after this guideline change, probably AZT will be completely moved out of our treatment guideline. That's something what will happen. So someone who fails TLD, which is very unlikely, which you have to improve adherence and make sure that they are really failed or not. If you have access to resistant testing, better to do that. Or if in the public health program, if you wanted to change with the resistant testing, then you can move them to one of the PIs. So today, the PI what we prefer is darunavir because it's less toxic. Once daily regimen is available. And as compared to atazanavir and lopinavir. Atazanavir and lopinavir from now on will become like an alternate PI. Darunavir 800 will become like a preferred PI. And also someone who fails TLD, you can recycle tenofovir lamivudine and put them on darunavir. It's something what we recommend in this new guideline based on the DEF study, which has been conducted in the multi-site, including in India and Chennai, and as well as in Sub-Saharan Africa, in Latin America, Thailand, and many resource limited settings. It's something, a new guideline change, which you can use in your clinical practice to implement. Moving to the other last change for your clinical practice is this long-acting injectable drug. I'm sure you might have heard about this many times from many CME lectures, including from myself in the same slides. As you all know that today we have 2 approved long-acting drug available, one called cabotegravir, which is like a dolutegravir, which is an analog of dolutegravir, digress inhibitor, which is developed with a half-life up to 3 months. Now, recently they have developed up to 4 months. Now, the one what used in this trial is up to 2 months. And also, it's been used in combination along with another second-generation NRTA called rilpivirine. It's also thought to work against people who have got resistance to smaller amount of resistance to nevirapine or efavirenz, which also had a half-life up to 30 days. So both together as a combination of Cabenova, so which got approved following 2 different pivotal trials, one called LATE-2, where they use this against everyday oral therapy every 2 months, where they found it's non-inferior. And they studied this in patients who got suppressed viral load with oral therapy, and which was well supported by two other trials called Atlas and Flare. So this all happened earlier, and following this, US FDA approved this combination as Cabenuva. So last year, the US guidelines, they updated their guidelines, stating that following these two clinical trial results, anyone who's on undetectable viral load, if they have viral susceptible both to cabotegravir and rilpivirine, so that means they never had an NRTA failure, never had an integrase failure, where you can change them to these two drug long-acting injectable. So last year they recommended and they started implementing. Then the question came to lower and middle income country to the WHO guidelines. So can we implement in resource-limited setting, particularly in our region where we have used a lot of NNRTA, like nevirapine, efavirenz, where they failed and they have higher level of baseline resistance of 10%, where we have moved completely to non-NNRTA containing regimen, can we use it or not? So we didn't have a good answer on that because all these studies were done in the rich settings. But there were some case reports, particularly from San Francisco, where they used on viremic patient, they started seeing suppression. But with few case report, we couldn't implement this. But there was a very nice study happened last year and presented at CROI early this year called CARE study, which happened in sub-Saharan Africa in 3 different sites. Where what they did is they on patients who got suppressed viral load, they would have even used NNRTA in the past, where they randomized into 2 different groups. One group, they received long-acting this injectable of cabotegravir and rilpivirine every 2 months. Another group, they continued that whatever oral drug they were on. So first 48-week data, last year they presented. And again, at the baseline characteristics of this particular study, not a new study, it's already been presented and published, where they had stored specimens in that they found that they had a lot of NNRTA mutations to earlier nevirapine or efavirenz. So, because again, in these participants, they had used rilpivirine, which is also an NNRTA, which will have significance for our regions. So 48-week results very clearly showed that both regimens, either everyday oral therapy or this long-acting injectable, both are almost the same in terms of virological suppression. There is no difference between orange color is a long-acting injectable, the darker color is everyday oral therapy. So the study happened, and they very recently they presented the 96 weeks data, where also they showed same comparable virological suppression between everyday oral therapy and this long-acting injectable. But here again, they use this in patients who have got undetectable viral load. So this was a very important study, especially in our context. Can we use it in our patients? And this was picked up, and this WHO guideline had an amendment stating that it's a new recommendation that anyone who's antiretroviral on antiretroviral therapy is stable and who have got a virologically suppressed, particularly on TLD regimen, that's what our current regimen, you can change them to cabotegravir and rilpivirine as an alternate ART switch. So we are not asking this a preferred, it's an alternate. So this is again because you all know that our patients' everyday therapy, they can tend to fail. So giving every 2 months is another way to boost adherence. That's what's been seen in these other studies in sub-Saharan Africa. But again, this regimen is not recommended if they have hepatitis B co-infection, and also not recommended when they have TB, because this rilpivirine is not fully evaluated in the context of rifampicin containing therapy. This is again a new recommendation. We can little debate during the panel discussion. Currently, this combination is not available in India or in resource-limited settings. Hopefully, in a year's time or so, it should be available through generic manufacturers. So we should wait for it, but we can have more discussion on this. So just to sum my first part of my talk, so these are the various new recommendations happen. There is a Darnur became a preferred new PI for second line. Of course, it is already for third line. And TAF has also been preferred as a first line therapy. And you don't need to use AZT anymore. You can recycle tenofovir or TAF even for second line. And the true drug therapy of dolutegravir and 3DC can be used for simplification when they are virologically suppressed in hepatitis B non-infected people. And of course, this long-acting rilpivirine is also been recommended as an alternate regimen to switch if they are virologically suppressed, if they don't have hepatitis B. This is something what's been recommended. I think it's time for us to go back and start implementing as soon as possible. And I'm sure our national program guideline will update the guideline based on these new WHO recommendations. So now moving to these, the IAS conference, some of the key updates. So I have picked up updates just to follow these WHO guidelines. What will make to the next guideline, or what you will be using that in your clinical practice, either in a program or in your clinical practice. So this is a very nice study, very important study, especially for our setting in the context of this WHO guideline, which recommended two-drug therapy on patients who have got a suppressed viral load. So this Impala is a study. It's a long-acting cabotegravir rilpivirine patients who have got a poorly controlled infection. That means they didn't have a suppressed viral load. They have been viremic, whether these drugs will work or not. Since the study was done in Sub-Saharan Africa, where patients who had more than 1,000 copies, so who had some adherence-related issues, where they were randomized, almost 540 patients who have been hepatitis B negative. They were randomized into two different groups. One group received this cabotegravir rilpivirine every 2 months, and another group they were continuing the same TLD regimen. That's a everyday oral therapy. So with the primary endpoint for this particular study is patients with the proportion of patients with less than 50 copies at week 48, and with many secondary endpoints, including some virological failure and as well as adverse events and acceptability of these injections and stigma and everything behind it. And I'm not going into the very detail on the baseline characteristics, but looking into the virological suppression at week 48, which was presented as a primary endpoint, and it's been found that very clearly the primary endpoint analysis per protocol demonstrated non-inferiority between oral therapy and as well as long-acting, even in patients who have been viremic. So all these times the recommendation was in people who are suppressed, but this is the first time in viremic patients in a clinical trial in a resource-limited setting show that it still works, and they have a good retention where patients came for repeated injections. So there were failures in terms of virological two viral load suppressions. But when they look into the analysis which demonstrated non-inferiority, and they looked at the virological failure patients, especially with the long-acting injectable with rilpivirine, there are 5 participants where their genotyping had been done. They all had NNRTA mutations. A few of them also had very low level of integrase mutations, except one which has got an intermediate. So these participants, what they did was they looked into the various risk factors, and following that, they again put them on TLD oral therapy, all got suppressed. So that means even if they had a viremic, they not working, closely, you put them on everyday therapy, it worked. Again, further analysis going on, we need to wait for more and more results. I think takeaway from this for our future guidelines is, can we give it for viremic patients? Here the earlier answer is can be yes, but we need to wait for more and more data on this. On looking at the safety of this, it has been very safe. Of course, patients who had injections, they all had some injection site reactions, but there are no one discontinued. And also there were some few pregnancies happened during the course of the study. And these women who were on this, almost 6 got pregnant, 4 had an elective termination, 2 live births, and all those kids were negative, and there is no neural tube defects results or any other defects they have seen in those infants. And very importantly, they looked into the satisfaction question, because everyday oral therapy, many of our patients love that, there's no problem. But on the hand, adherence is a major issue. So here we are asking them to come for injections. They looked into the participants' satisfaction questionnaires, and they found that there is more and more people who are interested to have these injections. It's just been significant. And also they found that 94% of them, they preferred injectable therapy than oral therapy. And in-depth interview also said that this is because of their privacy and reduced stigma, and for a lot of other various reasons that they preferred long-acting this injectable. So these investigators from Sub-Saharan Africa concluded that even in viremic patients, this long-acting injectable of cabotegravir and rilpivirine every 2 months, which has been non-inferior to oral therapy. Virological failure occurred in few participants, but they all got resuppressed. And this particular two-drug therapy was associated with very few viremic episodes, preventing transmission. And also it has been well accepted and safe. Hence, it can be future options, but we need a little more data on this. Which was also followed by another very nice presentation, but it's not a clinical trial. It's from a large observational database from the United States, from OPRA. I told you earlier, the US guideline is only on people who got suppressed, to change them to these long-acting injectables. So that is their US DHSS guideline. So in this particular database, what they looked into is, so anyone who's on antiretroviral therapy, they have a very large database called OPRA, almost around 151,000 participants on various antiretroviral therapy. Data had been captured on this, and they have several presentations over a period of decades on various regimens and toxicities and tolerabilities they have been shown. So in this, 3,304 participants have received a long-acting injectable in this particular cohort. Out of those, when they did a sub-analysis, 368 participants had received, even when the viral load is more than 50 copies, off-label. Because in the US, they strictly follow guideline. If at all you're going to give, it is offline because of their legal issues. So they had participants who had been more than 50 copies, almost 11% in this cohort had received this. Just looking at on those, only the 368, they looked into those adherence, persistent, virological efficacy. What they found in that is, so these are the patients who had more than 50 copies for a period of time. But when you put them on this long-acting injectable, they had 85% had virological suppression. So that means there are people who are not adhering to this drug, they have low-level viremia, get suppressed with this long-acting injectable from this observation data. So they very clearly concluded this very large observation database stating that by 6 months, 85% of the matured viral suppression less than 50 copies. So there are now evidences coming up soon after this WHO recommendation on suppressed people putting on this two-drug therapy, even on viremia, can we give them? So now we have data coming up, probably will again push the envelope of future guidelines. Next thing is, we may ask a question. We have been talking about this cabotegravir. Are they really safe in pregnancy? Because earlier when we introduced efavirenz, I still remember 20 years back doing a presentation on safety of this in pregnancy. Then we have dolutegravir, and today we have been talking about cabotegravir. So there is a large, very difficult to do a clinical trial on this unless someone becomes pregnant during a clinical trial. Now, we do have a very large registry which has been followed up, which is called APR, Antiretroviral Pregnancy Registry Program. So it's a very nice presentation from the registry, particularly on patients who got on cabotegravir. So not many people will have access to the registry. Only the manufacturer of cabotegravir, they had this access. So there is a presentation from them. So in this particular database, so they have almost 27,000 participants who had exposure to a variety of antiretroviral drugs, who had been exposed to these at various trimesters, first trimester, second trimester, all those are been analyzed. And in that, so they found that 42 of them will have cabotegravir exposure because the manufacturers had those details where they have distributed these medications. So they did analysis only on those people who had received this 42 and compared them against these other antiretroviral drugs. With antiretroviral drugs, so if anyone who are already exposed, not all antiretrovirals are always safe. It's already been seen. There are some defects had been seen, either miscarriage or stillbirth. All had been seen. They always compare this with the normal population based on whether it is statistically significant more than dead to make a recommendation that whether these drugs are safe. This is a common principle, not with antiretroviral drug, any drug, an antibiotic or a antipyretic or anti-inflammatory or any drug. Similar principle is being applied here too. So now on looking at these 42 cases who had been exposed to these pregnancy while on cabotegravir. So these are the distribution of various countries. Now you may laugh at me why I'm showing this. I still remember putting up similar slide 20 years back for efavirenz and some 7-8 years back for dolutegravir. So these are the various countries where these women have been pregnant. Might be in the next couple of years, even India might be also be part of this. So we had participants in first trimester, second trimester, and third trimester. So what's been seen out of these participants are, we put 43, I said 42, but there are 43 because one had twins. There are 35 live births, 1 stillbirth, and other spontaneous abortions and induced abortions. They did an impact analysis on all those live births, and they found that one woman gave birth to a child who had got a congenital ptosis. So a lot of work had been done on this particular participant, whether it could be due to the drug or due to other effects. So this woman exposed to these even 6 to 12 months before conception, even before that, and also had other ARV exposures before conception, including rilpivirine and also probably cobicistat and tafet-TC, and various other drugs, including folic acid exposure, were also been there. And they found they couldn't find any direct effect with this cabotegravir molecule on the structure of this for this congenital ptosis. So it could be totally unrelated to that. So on looking at this particular analysis on this large registry, which clearly shows that early positive safety say. We can't say that it has been 100% safe. Early positive. Similar things we did that for dolutegravir many years back. So the early positives, so they give confidence so that when they start using this, when they become pregnant, we'll have more and more data coming up from this. So you now show that it's really positive safety of this cabotegravir even in pregnant women. So moving to these other studies, so we all talk about same-day ART. This is one thing WHO's dictum on putting everyone on antiretroviral treatment soon after the diagnosis, which many of you have already implemented. We all did that in patients who are being asymptomatic, who had no opportunistic infections, immediately did that. Can you do it on people who are little symptomatic, particularly who have got a presented TB? Today, what we do is we rule out TB, put them on TB therapy, and after 7 days or within 2 weeks, we start them on treatment. This used to be called rapid ART. This is following large clinical trials we did called ACTG 5221. So following the results, we recommended as part of the guideline, which many of us have been using. So in this particular study, what they did is, can we even in those patients, can we start on the same day? So there's a trial happened in Africa, in Lesotho, as well as in Malawi. So what they did is patients who had symptoms of any TB, so one group, they did a TB diagnosis and they followed the WHO guideline of 7 days or up to 14 days. Then they started on antiretroviral drug. Another group, they started on the same day on ART after counseling the patient. Then they start digging into these TB diagnoses and put them on treatment. Now, which is very robust, which we don't do routinely in part of our clinical practice. Again, looking at the primary endpoint of HIV RNA of less than 400 copies, with secondary endpoints, very importantly, on hospitalization, IRIS, retention to care, and TB incident, anyone developing new TB. So when they look into that, between the two groups, you can see the same day group and as well as after the TB diagnosis put up to 7 days, they found that there is no change in terms of virological suppression between the same day and after the TB diagnostics. And also as part of the secondary analysis, they also looked into the TB prevalence and incidence, and as well as IRIS, which is very important because if you don't treat TB and put them on ART, every possibility can take IRIS. But in this particular study, what they found in it is very interestingly, there is no difference between the arms. So we're almost the same. So, and following this, these investigators concluded stating that even the same day ART, even they are mainly symptomatic, which has been non-inferior in terms of virological suppression, TB prevalence, hospitalization, and TB IRIS. And again, it can also support the other earlier recommendation on same day, even like in asymptomatic people. Can we implement in our region? As clinicians, I think we have to be a little careful. As we all know that in the context of any meningitis, particularly crypto, we have to delay because of the risk of virus is very high. In TB, earlier we recommended a rapid ART. So this is the first study aggressively done on this to show this, but we need to wait for more and more results. But on us, but you can take away in your clinical practice. There are some instances where patients got a very low CD4, 1 or 2 CD4, you rule out cryptococcal meningitis and PCP very quickly. We do not do TB diagnosis, take like a couple of days, or you have to put them on ART. Otherwise, there is possibility they can develop other OIs. If you want to use it, I think you can take it on case by cases. But we need to wait for more and more results, whether it can be generalized in our all patient, thing. I think treating TB and other opportunistic infection before treatment should be given a priority. But these are the results how you can use it case by case. So moving to the other studies, I think weight gain is always a major problem. I have discussed with your group in the past from our earlier updates. So in this conference, there is a very nice NIH-funded ACTG trial called A5391 has been presented called Do It. So what are the studies on? Patients who are on integrase inhibitors, either with the dolutegravir or with the bictegravir, if they have weight gain, can we switch them to non-integrase like a doravirine, which is a newly approved third generation NNRTI, along with tenofovir or TAF to combat this obesity and prevent weight gain. So again, this is a design of the study. These are patients who have got a BMI of more than 30. So they are the study population who all got a viral load suppression. 145 participants. They are randomized to 3 groups. So what they did was, one group continued the same, their standard of care, that is TAF FTC and the integrase, either a bictegravir or dolutegravir. And 2 test arms. One group received TAF FTC and doravirine, which is an NNRTI. Another group was changed to tenofovir FTC and doravirine. Because there are studies, including studies done in sub-Saharan Africa called ADVANCE, have shown TAF along with integrase have higher chance of developing weight gain. So can we switch them to TDF? So whether that weight gain can be prevented or not, they wanted to show this in a particular study. And again, it's a 145 patient study, but with a clear endpoint of showing that the power to do a weight gain between these two, and the secondary endpoints like a virological failure. So what they found in that particular study and presented here is, again, it's a little busy study. I'll just walk you through for 30 seconds on this. What they've shown very clearly is switching to doravirine from these integrase inhibitors just for prevent weight gain had no significant weight, any difference as compared to continuing on the integrase in all the three arms, if you put all together. Because one arm received TDF, another one on TAF. So all together, when you put into that, there is no difference into that. So they did a very sub-analysis of by race, by age, and whether any difference or not, because earlier studies have shown, particularly in Black Africans and as well as in Afro-Americans, where higher chance of being weight gain as well as in women patient population. So this is again a very busy slide. I don't want to go into details of very thing, but I'll just quickly show some snippets out of this, what you can take home for your clinical practice. So in the sub-analysis, what it then found is patients who are on non-Afro-American race, that is, who are not blacks, so other races, when they put them on tenofovir and emtricitabine and doravirine, so which had a little trend towards greater weight loss than the other things. So it's again a very small analysis which has been statistically significant. But for all the other different things on race, on putting in everything together, on the age, which has not at all been statistically significant. So this is something what needs more and more now work upon, that can we change from dolutegravir to other drugs, particularly not yet. But if as a whole, when you look into that, there is no change in terms of weight gain, but only in the small proportion of the population, they're able to see this statistical significance. They also looked into the data DEXA on all the study participants at baseline at 24 weeks and 48 weeks. And the analysis also showed there is no difference in between either with either with the integrase or with doravirine. All these participants received either they received TAF or TDF. There is no change where this doravirine didn't alter anything on this. So there is got no impact on the BMD loss. So these investigators of this ACTG 5391 DUIT study concluded stating that changing from integrase inhibitors to doravirine have no benefit in controlling the weight gain. So they also looked into the other safety matters, did not change any switch on that, and they concluded stating that we need other weight loss measures, not by changing from the integrase to doravirine. Really will help, except in one subset of population which needs more and more work on this. Moving to another study, it's a very interesting study. It's again a new molecule. Both are new molecule. One is a molecule which has been there for quite some time, going through various changes. It's called latravir, which is a translocation inhibitor, which inhibits at the level of the reverse transcriptase at the translocation level. Ulanivirine is a very new molecule, which is again a third generation newer NNRTI, and the preclinical studies have shown it works on majority of these patients who have got resistance mutations to variety of NNRTI drugs like nevirapine, efavirenz, even it can work against doravirine and as well as rilpivirine. This is a phase 2b trial which campaigned against latravir. So latravir is a drug which gone through various types of trials and had some issues on lymphocyte depletion, and because of that they modified the dose. Now here, they again did dose ranging studies before they picked up for this phase 2b trial as 20 milligrams, and they combined with this newer molecule of ulanivirine, and this is again week 48 results was being presented with the primary endpoint of adverse events and as well as in virological success. So I'm not going into the very detail, but I like to tell you that there is no confirmed virological, very robust, this molecule of this two drug therapy of this translocation inhibitor, as well as this newer NNRTI, ulavirine, which has been very robust, that nobody failed. That's great, at week 24. So they just have them of week 48, which will be presented soon. So the first 6 months data very clearly shows that it's such a robust molecule when you put the patients on this particular thing. But they looked into those very detailedly on the adverse events, which has been comparable across arms. So what they found in that is patients were on latravir, of course, all those groups were on, the latravir. And again, they found that there was a reduction in the lymphocyte. It's been seen in all their previous studies. And based on that, they reduced the dosages to a very lower molecule, and they conducted the study. So here they had a good, robust virological suppression and no other adverse events except this CD4 loss, and is attributed to this Latravir. So the investigator concluded that it has been very robust in terms of virological suppression. But on the other hand, the same strength of 20 milligram will not be used for the future development. So they picked up a dose on a small scale study of 2 milligrams, and where further work will be happening. Because the phase 1 data, what they showed with the 200 milligrams, so they had a lot of variety of conflicting results with Latravir when combined with the different molecules. When they combined with Ulaverin, they found when they combined 20 milligrams with other molecules, non-Ulaverin earlier molecules, they did not see this. With a higher of 40 milligram, they saw that. But now with Ulaverin, they are seeing this CD4 reduction. Hence, they want to pick up a much lower dose, and they have already constructed a phase 2 trial, which will go on heads-on. So this is something what we need to wait for. It may take another couple of years, whether it is, but it's very robust, clearly shows that it can be a molecule for future, even for research-limited setting, can be co-formulated as a single pill, especially for maintenance therapy, even in patients where you don't want to give dolutegravir. Again, further work will happen, particularly in the context of weight gain. So this the future trial will address whether Ulaverin will have anything. So now it is too early to say from this particular study, but there is a question on that. But on the other hand, the future trials will answer whether it will also answer some of the metabolic things caused by the integrase and as well as the weight gain issues. Moving to the next study, so it's just a new molecule, is a new class of drug. It's a molecule called HRF1-0071, which is a phase 2A dose-ranging monotherapy trial, which is a next-generation maturation inhibitor in people with HIV. So I was fortunate enough to clinically develop this molecule, and I presented at this conference. So this is a molecule, it's a Make in India molecule, which was developed by our Hetero Labs. This is an investigational drug. It's a next-generation maturation inhibitor, which blocks cleavage and maturation at the time of gag capsid production. So this is a very new class of molecule, as compared to a lot of other things which has been developed in the past. Our preclinical studies have shown this particular molecule has got a reduced susceptibility to current, all the other, where it works against even other resistant strains. So that means it could be robust. And healthy volunteer trials, what we conducted and already shown to our Indian regulator, shows is tolerable and suitable for once daily, dosing. So in this particular conference, we reported the monotherapy dose ranging study in treatment-naive people to show how it is virologically being efficacious. So just to go into the design of the study, I just want to walk through the mechanism of action. As you all know that we have different enzyme pathways. So one of those very important pathways is maturation. Right now, there is no major molecule. We have one called capsid inhibitor, lenacapavir, recently approved. So there is nothing at the maturation level. What is this maturation? So this particular molecule of 10071, which we presented, acts at this level. How it acted is in the maturation inhibitor. So what happens is usually there is a mechanism happens which is called protease cleavage for HIV, and which help to release its mature virions, which butts out and goes and attacks at the fresh lymphocytes. So this particular molecule, 10071, which blocks this protease cleavage at the capsid level, where we call spacer protein cleavage. And because of that, what it happens is it causes immature particles to be released, and thereby it will be non-infectious. It is a very robust, it's a new mechanism, which is a new class of drugs, which has been developed, and now the study has been studied in people living with HIV. So it was studied purely in India, so dose-ranging study on 30 HIV-infected people who are treatment-naive, no opportunistic infection. They have CD4 of more than 350. They have been very healthy people, more than 5,000 viral load. So this is a group received a placebo, and there are 4 other groups with the different doses, 20 milligrams, 30 milligrams of this molecule, 40 and 80. Then this is as per the Indian regulators' sample size calculation to show various different virological suppression as well as the safety events before the next phase of drug development. So the primary endpoint of change in viral RNA from baseline to day 14. We are doing viral load at baseline, day 1, day 3, day 7, and day 14 onwards and compared with the baseline. And also with the secondary endpoints with various PK parameters. And of course, we also looked into the CD4 decline because of these latravir used in other trials, and the safety and the tolerability and the adverse events. So this is a baseline characteristics, which has almost been same in across the different arms. And most of our study participants are less than 100,000, but we also had patients with more than 100,000 viral load. And when you look at the change in viral load, if you look into those different regimens from baseline to 14, it has been virologically suppressed across the different different strengths. And if you look into those change in viral RNA over the different time points from baseline to day 1, day 3, day 7, 10, and 14, and it has been hugely statistically significant on all those different doses, and this very clearly shows that this drug has been so effective in a way that it has been very, very robust in terms of virological suppression in the very early development. And also, we looked into the pharmacokinetics of the various different time points from day 1 to day 14. And we found that exposure to this particular HRF molecule increased proportionally with the doses, and they achieved the day of day 10. In a drug development, the day 10 is a very important phase where they maintain that, and maintenance happens, and which is needed for these virological suppression. And also we found that this concentration accumulated 2 to 3-fold per dose, which was expected and it's been seen particularly in this molecule. Looking into the safety, it was very safe in healthy volunteers. Looking into the persons living with HIV, which are all safe. They had few adverse events, they're all very minor, not related to these any study medications. No one discontinued. There is no serious adverse events or anything being reported. It's been found being safe. So we concluded this particular novel maturation inhibitor, stating that it shows they have a dramatic drug reduction, viral reduction from baseline to day 14. And in this, we also looked into patients who have been very mildly viremic, looked into any resistance mutations. There are 3 persons who have developed maturation inhibitor mutation, which is expected in all the trials when they do a drug development, because when you give us a monotherapy, but we expect this won't occur if you are combined with other antiretroviral, because we are not going to give in our clinical practice this as a monotherapy alone. It's a drug developmental phase. And pharmacokinetics showed it has been dose-related increase had been shown and over exposure, and all those doses are very well tolerated. Now, we have been planning the next phase of this drug development of a Make in India molecule of HR-0071 in combination with the other ARVs, which is routinely being used as part of our practice. You may see this over a period of years, how this drug is going to be developed and as a new class of drug. And also, I'd like to tell you that this drug also has got a potential as a long-acting. We are also looking at it as a long-acting injectable, both for treatment as well as for prevention, which may see this over a period of years. Other long-acting investigational drugs, which are being presented at this conference, which are all capsid inhibitors in a very preliminary phase, and as well as a 3rd-generation integrase inhibitors. I don't want to go into the details of all these details. Just to conclude my presentations, I usually do this type of slide after every presentation after the IAS conference or CROI. What are the new drugs which are under development, which may come up? Plenty. So even at the reverse transcripted, you can see this variety of this red-colored drugs. Some of them are put on hold for various reasons, and some of them are in the early phase development. In capsid inhibitors, and as well as in the INSTI, there are a lot of new drugs coming up. Some of them are put on hold. And as well as we also have drugs at the maturation inhibitors, including our own molecule of 0071 is all development. So that means there are a lot of robust antiretroviral therapeutics in pipeline the next several years, where you'll see more and more drugs will come part of our guidelines. Now, to end my talk stating that from this conference, whatever we heard is HIV therapy, antiretroviral therapy is lifelong. You cannot stop it, and several factors contribute to this. I think preventing resistance will be the future question. Everyday oral therapy has issues. Hence, long-acting, high genetic barrier combination antiretroviral need not be a injectable, but can be even a oral tablet, can also be an answer. Hence, our future therapeutics will be, it's not just on everyday oral therapy, but also on the other hand, giving a lot of long-acting drugs whenever it's needed. Already now part of the guidelines of Cabelle and also Vilpirin, but more and more new drugs will be part of our guidelines. With this, I think I'll stop, and we'll take up any type of questions, and we'll have a panel discussion on this. Again, thank you for your opportunity. for presenting to you, and thanks for the patient listening. Thanks.
Yes, thank you, Dr. Kumaraswamy, sir. It was a very enlightening presentation, and as always, excellent one, sir. So thank you very much for the valuable insights. I hope you can hear me.
Yeah.
Very well.
Yeah. Thank you, sir. Thank you, sir. So as we wait for the few questions which might come in the meanwhile, let us start with the panel discussion. I hope I'm sure few doctors have visited the Kigali conference in Rwanda. So I like to ask the first questions. The first of the questions to Dr. Vijay sir and of course Dr. Gilada sir. Sir, so in the conference, sir, what are your insights during the conference? And the second part is the overview of WHO recommendations. This was recently released during that conference. So what's your take on this, sir?
I think like Dr. Kumar said, I think the most interesting part is what we'll be doing with the long-acting drugs, okay? And particularly because I am part of the national program and I sit on the TRG, what we look at, the national program will always be looking at cost, obviously. But I think that, more and more we'll be seeing that as costs keep coming down, and we are looking at the program trying to address the last mile. So we need to look at those small numbers of people who are very difficult to manage. And this is where the long-acting drugs play a major role. So if you think about it, if you think about the efficacy of a vaccine, for example, okay, and if you say that if you can prevent 80% of the infections, then that is a good vaccine. And we know that undetectable is untransmissible. Yeah, and this is the area that I think is the most exciting part. So clearly, we will have to take a much closer look at the long-acting regimens, both as treatment, but also for PrEP. Dr. Kumar did not dwell much on the PrEP side, but that's another area that is very, very promising. So these are the key things that it took away in terms of antiretroviral therapy. The other part, I think, is the understanding universally now that we need to pay attention to all the other stuff that's going on with HIV, the STIs, the chronic metabolic disorders, chronic liver disease, chronic kidney disease, chronic neurologic disease, because our patients are living longer and longer. And then the prevention of HPV-induced cancer. So I think that these are some of the areas that clearly we need to pay a lot more attention to.
Right, sir. The same question, sir, I would like to ask Dr. Ishwar Gilada, sir. Any views on the conference highlights and, sir, your take on the 2025 recommendations issued by WHO during the conference?
See, WHO is known for ritualistic guidelines. And whenever there is they wait for the guideline may be ready for a long time. They just wait to get that kind of importance or prominence for their guideline during the conference. Number two, WHO guidelines are usually followed mainly in Africa very quickly. India takes long time. India may have some differences with WHO understanding, maybe programmatic differences, but it will take longer time in India to implement that. Thirdly, as Vijay said, that in India we look at cost. If the cost difference between atazanavir and darunavir is too high, I don't think the way atazanavir is presented as a villain, it is not a villain. And we don't find the initial apprehension about atazanavir which were projected that high in real practice. Secondly, India has other problems which are not yet solved. We are stuck at first 95. If we look at African countries, smaller, poorer countries, where we have seen 30 years before, 20 years before, people were dying like ants and they were collecting dead bodies to do mass funeral, they have excelled in 95, 95, 95. The 7 countries, particularly Zambia, Zimbabwe, Lesotho, Eswatini, Swaziland, which was Swaziland earlier, Botswana, Namibia, and Rwanda, they have achieved 95, 95, 95. Not only 95, 95, 95, they are around 98, 97 in many of the parameters. In India, we are stuck at 84. It was 78 till couple of months before. So I doubt whether it is 78 has become 84. Because 2 things we are not able to do is PrEP is not part of official program, where all over the world PrEP has been accepted, even in a lot of countries of Asia. HIV self-test is not part of the program, where some population, which are inert population, they don't want to go to ART center because of some sexual minority reason or any reason. If we are able to do HIV, diabetes self-test at home, COVID self-test at home, pregnancy self-test at home, why not HIV? So somehow we are stuck there, and every year me, Kumar, Vijay talk from inside and outside both, but it is not happening. We are not able to move the government. And thirdly, whatever new drugs come or which are found good, I don't think it will be immediately implemented in India because our central FDA is a big problem. They want every trial to be done in India. For example, the best combination, if anybody can have, is rather than in the what you call first line, rather than TDF TAF plus 3TC plus DTG. This combination is made in India, supplied all over the world, but it is not available in India as a single drug regimen. So I think we need to fight with these forces first, than talking about whether WHO guidelines will be implemented in India and how it will have an impact. So I think we are stuck here. Over to you, Ketan.
Thank you, sir. Thank you, sir, for your very passionate reply. Thank you, sir. And now the questions are coming. So the question is the preferred ART in CKD and CLD in treatment-naive patients. So he's asking for the opinion. Which is the preferred ART? Yeah.
So maybe I can take it. Someone who already have a CKD, chronic kidney disease, I think you can't give tenofovir. You can give TAF based on the creatinine clearance. So we have a formula. If they have a creatinine clearance is 50 and above, or 30 to 50, 20 to 30, and 20 and less. And based on it, you can choose it whether you can use a TAF or not. So I think the easiest thing is we have abacavir in our settings. So it's also been available as a single tablet, abacavir, lamivudine, and dolutegravir, which could be a preferred one. Coming to these liver disease, I think it's very importantly, before you put them on any therapy on these people with the liver disease, we are initiating, I think, rule out the cause of this. It can be due to hepatitis B or hepatitis C, or could be due to other infections or alcohol liver disease. I think unless you stabilize all those, you put them on therapy, they may go for, hepatic failure. I think it's very important on a case-to-case basis. And again, someone who has got an altered liver function test, and if they already have a chronic active hepatitis, so one drug which always you have to avoid coming to the antiretroviral therapeutics is based on the currently available regimen. Earlier we used to avoid nevirapine and all those. Is all the protease inhibitors. You have to be very careful because anything with on a ritonavir boosted protease inhibitors can cause problems. But the one usually because major problem if you're using more ritonavir, particularly with the lopinavir. So Darnor can be much better, but on the other hand still can be there. But I think still preferred doing is TLD. But on the other hand, ruling out other causes and stabilizing the liver is very important. I'll also go into just for one of time, going to the other question just asked by Dr. Anand Rao, is on preparedness on the same day ART. This is something what robustly, implemented by WHO some years back. Someone who is totally asymptomatic, you can counsel the patient. If they're agreeable, you can even start on the same day. So this is again based on large amount of epidemiological data gathered in sub-Saharan Africa as well as in other parts of the world on the loss to follow. People who are asymptomatic, when they come to you, you tell them, yeah, you're doing well, come every 6 months for a regular checkup. People are not going to come here. Then again, they'll come to you only after 5 or 6 years when they're really sick and come to your ER or ICU and they may die of acute opportunistic infections. So, and by the time they might be viremic, they might be transmitting to their sexual partners. So we had two pivotal studies. One is a HPT-052 done many years back on treatment as prevention, and as well as START study, where starting treatment soon after the diagnosis showed it not only prevented opportunistic infections, but also prevented non-communicable diseases and several other immune activation-related disorders. And for this reason, starting treatment very early and as well as retaining them into the program is very important. And so this robust recommendation was made. Now, coming to the question, context of today's my presentation on the SADUP study, where they had studied even in people who are symptomatic. So because our earlier guideline, we also said that people who are symptomatic don't start on treatment immediately, stabilize their OI, put them on therapy, make sure that they are adhering, then you start on treatment, at least 7 days on TB and crypto and other neuroopportunistic infection in a time after 4 to 6 weeks. But this is a study robustly done. But again, I it's concluded stating that you have to take in the context of each patient. Don't immediately do on that. Continue with our earlier guidelines. But these are the trials, but we have not updated the guidelines based on this particular recommendation, but we need to wait for more and more results. So one of the things, I'm a big fan of rapid ART initiation because it's very important because the current regimens, particularly with the dolutegravir integrase inhibitors or bictegravir, have had a very robust virological suppression. So within studies have shown anything from 8 days to 2 weeks, you can even see undetectable viral load, which can lead to prevention effects. And we talk about U, I think where this really helps. And also when you talk about a lot of other immune activation disorders, starting treatment very early is very important, since implementing that particular guidance and counseling the patients, accepting, make sure that patient take this drug every day is all very important if you talk about same-day ART. Maybe Dr. Gilada, your experience on same-day ART?
No, I think even if we don't give, people go Google, they come and they say that everywhere it is given, why you are not giving. So when we don't, actually, rather than starting same day, we need to tell them why we cannot start same day for that person. We have to exclude those people where you have a CD4 count very low, whether CRAG is positive, whether you are expecting tuberculosis and you want to do priming, then we are expecting PCP and patient is already dyspneic and you want to first treat at least for 5 days and then start. But at the same time, what we do, we tell them same day, but we say, okay, you start this medicine after 5 days, after taking priming of the cotrimoxazole treatment and then prophylaxis. So we have to go with the current scenario. We cannot go that we are having a different opinion.
Thank you, sir. So, yeah. So here there is another, I think, follow-up question from Ananda Rao, sir. He's talking about at least 2 sessions of preparedness counseling are probably needed before the client is willing to engage in a lifelong ART treatment, especially in illiterate population. So, yeah. So I think we'll have views on Dr. Vijay, sir. So, yes.
I think there's a misconception. There's no such thing, because even people who are quote unquote illiterate are not stupid. I mean, once we sit down with them and explain to them, what's going on in a language that they can understand, I think that's the key. And, for me, when I was in the United States, the bulk of my patients spoke English, but when I had a Spanish-speaking patient, but then I had to get hold of an interpreter and make sure that the message was properly communicated. And the key thing that this is the one area that we as healthcare professionals have not done a very good job is, we assume that simply because we have articulated whatever we wanted to say, that the person has understood. I think that's where we go wrong. What we need to do is ask them to articulate back to us what they understood. And once that communication has occurred, it doesn't really matter what background they come from, unless you are dealing with an individual with major cognitive deficits. It's not a difficult thing to make them understand what's going on, what needs to be done, and how, most importantly, how this can help them maintain good health.
Yes, sir, thanks. Thanks for this thing. And this question is, of course, for Dr. Vijay Lendi, sir, because he has a lot of experience for HIV and so many years. So basically, this question, see, this is a panel discussion question. So what do you think are the most significant improvements made in the last decade for the global response to HIV and STIs? So even Dr. Gilada sir can answer because he's expert in STI.
I
as
think
well.
that the key important advance that we have made is availability of rapid point of care testing, okay, especially the NAT-based testing. The thing that we still struggle with is the clinicians who are managing these patients are not paying enough attention to the STI part, and in particularly, looking for the concomitant STIs as well as communicating to them what the differences in risk of transmission are of HIV vis-a-vis STIs. For HIV, we say, look, you're on antiretrovirals, you're undetectable, therefore untransmissible. Well, that's not true for the other STIs, because unless you are using barrier methods of prevention, like condoms or so on and so forth, you can still transmit STIs. And if you don't go on looking for it, you won't find it. And the problem is, in a public health dimension, a lot of people with STIs are asymptomatic, and they keep on transmitting those. And we now have 3 decades worth of data, evidence to show that concomitant STIs actually increase the efficiency of transmission of HIV. So this is a big deal. I think on 2 fronts, the good side is technology is better and it's actually easier and faster to make the diagnosis. The bad side is we haven't done a good enough job.
Yeah, I agree with Vijay. Basically, if you talk about improvement, yes, in last 10 years, what improvement has been done, people are surviving. Earlier, they were asking, they wanted to see their daughters or sons' marriage. Now they are asking, they can see their next generation's marriages or any kind of improvement. Secondly, viral load testing has happened in India and globally. Cost of medicines have gone down. Importance of India has been there. A lot of millions of lives have been saved. So I think earlier, now also, unfortunately, the big agencies like WHO, UNAIDS, or Global Fund, they do not acknowledge name of India, despite the fact that 92% of the world's PLHIV are taking Indian medicine. I think they feel shy to take name of India, and we need to emphasize that on that. Now, HIV, there are 2 streams of people working in the field of HIV. Those who have understanding of STI and those who do not have understanding of STI. Unfortunately, the second part is bigger. And in that sense, HIV work has done a great disservice to STI. By PrEP and by PEP, it became totally HIV-centric policies. And therefore, what we have seen in last 10 years, resurgence of STI. In 20 years before that, we've seen STIs going down, down, down so much that most of the dermatologists started cosmetology practice. They stopped their STD practice. You will agree with me. But now we are seeing resurgence of STI. When I was in JJ, or 40 years before, 35 years before, we used to see 8 or 10 gonorrhea, chlamydia every day. Then we hardly seen during a year, hard of 1 or 2. Now again we started seeing twice or thrice in a week. So I think resurgence of STI, lot of HPV is there. HPV MSM, male to male sex, is very high. In our small study of 200 people, 64% of them have high risk HPV, and 16, 18, and 45, that is in more than 50%. So these are the problems. Simple logical things like 2 tablets of or 2 capsules of doxycycline is not offered by people. We talk about a lot of things about HIV and we do not do that. And most importantly, at every nook and corner, we do hepatitis B test. You go to pre-surgery testing, inpatient, pregnancy, STI clinic. But after that, they don't tell that if you are hepatitis B negative, you should be vaccinated. The cost of vaccination is peanut. The government of India has thankfully included hepatitis B vaccination program in extended program of immunization from 2011. but that is only for newborns. It is not for adults. So I think we need to emphasize on those things. And if we need to, like it will be piggybacking. Initially, HIV spread because STI was high. Then we control HIV, STI was controlled. Now STI is again going up, so it will again piggyback on HIV. And we'll have a big issue with, and no STD has gone away. Despite having 100% cure on syphilis, gonorrhea, chlamydia, chancroid, donovanosis, they are still there. So they are ping-pong infections. So HIV is also not going to go away. They are going to stay. It will be up and down between HIV and STI. Sometimes both will be up, sometimes both will be down, but again, sometimes up and down. Please unmute, Ketan.
Yeah. So we'll take one more question till maybe the questions from the audience are coming. So the next question is like, what are the biggest challenges you see in implementing the WHO 2025 recommendations for India?
So coming to these WHO recommendations, whatever I walk through, so many of them are already there. Already people are doing. So we see TAF. It's already widely implemented in the private practice in India. So it's a question of fine-tuning the national guideline. And coming to changing from recycling tenofovir again to tenofovir second line, you don't need any big guidance. We have proper evidence to move that. And very importantly, bringing in darunavir as part of the second line. So currently they have been using arachnavir or lopinavir. So now darunavir is available. It is marginally expensive than arachnavir. But on the other hand, long-term toxicities to arachnavir and also unacceptability of various things on hyperbilirimia, yellow eyes, and discoloration, which will bring merit on darunavir. That's something to be implemented. So, and very importantly, our national program should look into the true drug therapy, that is dolutegravir and 3DC. So, which is now part of the guideline. And for this, as Dr. Gillada very clearly enumerated, that doing this hepatitis B testing, where even you are implementing, that will also bring into part of our regular routine practice. Do testing, they're negative, do a vaccination, and if they're positive, then don't change, continue the same TLD regimen. So these are the things very easily can be implemented. But on the long-acting injectable, now part of the guidelines, but we don't have a drug. Even in South Africa, they can't implement, unless MCure brings a molecule on cabotegravir and rilpivirine to us, we'll not be able to use it. I think this is time that it's part of the guideline. So big appeal to all the generic manufacturers, both from India and from other countries. It's time to look into this technology so that our patient population will be benefited.
Okay. Thanks, sir. So Dr. Vijay, sir, your comments on this?
Well,
Of course, you can elaborate on US also as well, if there are any challenges there.
See, the United States is slightly different. Okay, we have a greater availability of all sorts of agents that we can give to our patients. All right. In the United States, there is one small group of people, particularly in the inner cities, who are difficult to manage because they have underlying mental illnesses or they have substance abuse problems. Okay. Now, that kind of a recalcitrant population is much smaller in India. The problem that we have in India is our public system, which manages the bulk of HIV infections in India. We are constrained by resources, okay? Adequate personnel, adequate training, and then managing this very complex system throughout the country. You go to one state versus another state, everything changes. The language changes, the cuisine changes, the culture changes. So in the context of what we can do in the public sector in India, mind you that we now give antiretroviral therapy for free through the public system. We also do the viral load testing for free. We do the hepatitis B, C screening for free. We do the CD4 and opportunistic infection management. Everything is, at public expense. But the strain that is put on limited resources in terms of trained people who can do a good job and then monitoring that activity is quite a task. So under the circumstances, if you look at the magnitude of the task, the amount of resources that we have, the diversity of India as a continent, because I like to remind people, unlike Africa, where you are dealing with small countries, India is a continent. So if you think about one state in India, it will be like one country in Africa, or in fact, it will be 2 or 3 different countries in Africa put together that makes one state in India. So the scale, the magnitude, and the complexities of the implementation part is very different in India. The challenges are quite significant, but nevertheless, making progress. And I must say that we will have a lot more availability in the public sector in terms of, doing things properly. We are now, NACO is setting up 2 drug resistance testing laboratories, one at NIMHANS and one at All India Institute of Medical Sciences in Delhi, which we are helping them set up. We are the technical partners for setting those labs up. So it is coming along little by little, little by little. But if you look at the private sector is already doing everything, okay? It's just that it approaches a very small proportion of the entire population. So we have PrEP in the private sector, we have PEP, and pretty soon we will have, as soon as it is available in the market, the long-acting agents. I think all of this will be done in the private sector. But my concern still is that even in the private sector, where resource constraints are not as severe, the clinicians need to do a much better job at looking at STIs, looking at concomitant illnesses like hepatitis B, C, HPV, etc. And also immunization. This is a big, big problem. We're not doing a good enough job preventing a lot of preventable infections, giving them, for example, just giving everybody pneumococcal vaccine, giving everybody influenza vaccine. So these are very simple, easy things to do, all right? And this is where we need to do a much better job, both in the private sector as well as in the public sector.
So there were 2 clinical questions. One is on, again, same-day ART. Dr. Bora has asked a question on in the context of toxo, penicillosis, cystoplasma, cryptococcosis, what about the same day? So today we have a guideline only in asymptomatic people, no symptom, nothing. It is recommended to start on the same day ART. In all the others, you find the OI, treat them, stabilize them, then you start. If they have a TB, you can start them within 7 days. That is what is called rapid ART. But on the other hand, if they have any CNS infections like toxo, cryptococcal meningitis, or TB meningitis, you treat them well up to at least for 4 weeks to 6 weeks, then you start them on ART. I think that guideline is implemented, you should follow. So today in my presentation about the setup trial, there are early evidences coming up. Can you give, especially in the context of TB, start treatment early? But again, we are not recommending with that one particular study. It is something what's been seen. If you had already used in some patient, you missed the TB diagnosis, don't worry, continue the ART. Don't disrupt that till you can, catch up. So, and also there's a comment from Dr. Parvati from Ernakulam. I think we should laud Kerala for doing this. They have already vaccinated 90% of their patient population with hepatitis B, and a lot on HPV vaccine on their adolescent young girls. Hats off to them, to their state and their program. I think rest of the country should learn from them. So, and another question on a 2-drug therapy of dolutegravir and lamivudine. Now, currently it is recommended only on people who have suppressed viral load. So you have to start them on 3-drug therapy and make sure that within 6 months they got suppressed, then you can change them to the 2-drug therapy. But there are trials have shown, even on naive patients who are very weak with suppressors, at this time, we are not doing the recommendation because of lack of large level evidence on the generalizability of that particular trial. So at this time, it is only on people who got suppressed viral load. Anytime after 6 months, you can do that. And there is another question on cost of pneumococcal influenza vaccine. I think pneumococcal vaccine has been one time. So if you do at the appropriate time, which will have a lot of benefit, especially in people who are, in anyone who is HIV positive, and particularly people who are all 50 plus will be benefited. And flu shot every year annually, it's recommended. Again, it's our own behavior that even many of our clinicians, we don't even, do our flu shots. So in this country, but it's very important because our patients, they're prone to develop all these infections and become morbid. Because with antiretroviral therapy, we make sure that they do well, but other comorbid conditions should not cause any problems. Better to implement at whatever level you have, but it's not part of the national guidelines. But people who can, I think it's right time we should do this patient literacy program on our patient population, make sure that they invest on these interventions. I don't think there are any questions.
The
Over to
pneumococcal
Dr.
vaccine, it's not very expensive. The polysaccharide vaccine is around 1,400, 1,500 rupees, something like that. But the polysaccharide vaccine does have to be given every 5 years. It's a conjugate vaccine that you can give only once in a lifetime, but that's about 4,500 rupees. So the conjugate vaccine is expensive. But look, something is better than nothing. And I really, for people for whom cost is an issue, I still recommend that they take the polysaccharide vaccine.
Hi, sir. So we'll have one or two last questions. So here the question is, the WHO has endorsed the policy of self-testing as an important tool, as it increases the access to HIV testing. So we just wanted your view on it, especially for India, sir.
You see, basically, HIV self-test has been approved for last 5 years, and many countries in Asia and Africa, they follow. Our attitude, I don't understand why it is that what we are telling people that we will not give you PrEP and we will not give you HIV self-test. If you get infected, we'll look after you for whole life. We'll give you free ART, we'll give you free viral load testing, we'll give you free medical care. So I think this attitude has to change. And this is at what cost? Whose cost? We are all taxpayers. And adjoining to that is also a problem where not every PLHIV is asking that they should be given free treatment. So why we are thrusting free treatment on them? It is like you come in Mercedes cars and take free ART from ART center. So this is, we have to change. We should have a preferential pricing. And we should also have a public-private partnership in real sense. It is not just for the kind of symbolic phenomena. Good public-private partnership exists in National TB program or TB elimination program, where a practitioner can write any TB drug and that is available. The private sector, which is also authorized by the National TB elimination program, they can get bedaquiline, delaminid, all these drugs just within a call. TB tests are done free of charge. Here in HIV, if we send our patient to ART center, first and foremost thing is that the patient is bashed by the ART officer. Oh, okay, you finish with money, therefore you have come to ART center. So that attitude has to change. And though directly kind of private sector is contributing only 10% of ART kind of patient in PLHIV, but 20% patients, they are in public sector and they come and take advice from us, or they are referred by us to public sector, but they are following up with us. So there are 30% patients at stake, which have to be looked after by private sector. So we cannot ignore private sector at all. And we, as a body of AIDS Society of India or HIV expert, we have offered our free of charge help to Government of India. Whenever they want to help, take our help, we are available. But I think that help is not taken seriously, and we are going with the same program, providing everything free, and someday that will collapse because the same thing collapsed in other programs where everything was free.
Yes, sir. Thank you, sir. Thank you, sir, for your comments. So there is another clinical question from Dr. Malakar. If the patient is hemodynamically unstable, asymptomatic, found in emergency department, incidentally, what is the recommendation?
Well, I didn't get that question.
That question is not clear.
Hemodynamically stable, unstable?
Unstable. I think.
Look, so in the context
that
of
question is not clear. So
yeah,
we'll take
so
the
look,
next question.
Anybody who's hemodynamically unstable, it's the same thing that we do. It's airways, breathing, circulation first. Okay, and you can do the diagnostic testing if you like, but antiretroviral therapy is not going to make a difference in a hemodynamically unstable patient for a very simple reason. There is no viral infection for which an antiviral drug reduces the virus by any significant amount in less than 7 days. It doesn't matter whether it's hepatitis B, hepatitis C, HIV, herpes simplex, cytomegalovirus, you name it. Okay. So clearly, with a hemodynamically unstable patient, you focus on clinical stability, which is airways, breathing, circulation. You can add the antiviral drugs whenever you like for whatever it's worth, but that should not affect your judgment in how you manage a hemodynamically unstable patient.
We always say
Thanks
that
for that
ART is
advice.
never emergency. ART is not an emergency treatment. Whether the CD4 count is 1 and viral load is crores in per ml of blood, still it is not emergency.
Thanks, sir. Thanks, both of you. So this question from Dr. Ashok, do you suggest HPV vaccine for, that is the Adarasil 9 for people over 25 years of age?
Well, so that's a very tricky question. I will tell you that the current guidelines have some very specified age limits where it's recommended and blah, blah, blah. I think there's no science behind that. That's my problem. We went through the same concept with hepatitis B, because when hepatitis B vaccine was introduced, they said, look, we'll give it only to high-risk people, and then we'll give it to people who become sexually active. The presumption there being that people will not get a sexually transmitted infection before they hit a certain age. And that entire strategy was proven to be wrong. So that's why I think that, HPV vaccine should be introduced at an earlier age for everybody, okay, before they have any chance to get the infection, because the vaccine that we have prevents infection. But once infected, does not prevent disease. So this is clearly a great deal of rethink needs to be done about the entire strategic approach to eliminating HPV as a problem.
But Vijay, you are telling about 9-valent vaccine. 9-valent vaccine is very expensive. Currently, quadrivalent is both available from Indian manufacturer and international, and the cost is quite considerable. So I think, and
but the cost will come down if we decide that we want to use it on a mass scale.
Yeah. But that has been said 2 years before. It has not come down. Cost is half the international cost, but it has still be prohibitively high. And secondly, in the national program, they said that it will be only for female. But they don't understand that female are infected by males. So
and males are also infected by males.
Yeah, males are, and so if you have a limited pie and you want to spend, you should spend on male than female.
Right. That's why I'm saying, one must make a distinction between the biological construct and the science behind it and the pharmacoeconomics of any kind of intervention that uses any of these drugs. But those are two separate issues. Costs can always be brought down. Technology, vaccine technology is evolving and costs are coming down, but we must make a policy decision that this is a virus-induced cancer that can be eliminated. And that's the key.
Yeah, thanks, sir. Thanks, both of you. So we'll take our last two questions. Yeah, so before that, Dr. Murugesh Pastapur is saying, excellent talk, sir. And many of the attendees have even thanked the panel for your advice to them. So thank you very much. And the last two sets of questions we'll take. This is from Dr. Hemant Patel. So should LFT is LFT recommended for all HBs AG positive patients? And should hepatitis B positive patients who needs LFT start ART?
Look, the transaminase is going up, maybe caused by hepatitis B itself. Okay, so really, if you are somebody who has evidence of hepatitis B infection, you have to look at the liver enzymes. What is good is that hepatitis B happens to be one infection that if you bring the viral load down by using a specific antiviral agent, all right, And it doesn't matter which one you use. Tenofovir is what we use in the HIV program. But if you can use entecavir and show that when you bring the viral load down, the transaminases also come down. Okay. Now, there are a small number of people who spontaneously clear the hepatitis B surface antigen from their blood, and they remain stable. But I think even those people should have very close follow-up, because it's very clear that those people who have long-term hepatitis B infection are at a higher risk for liver cancer. And yes, there are a small but very small minority, but nevertheless existing minority, who, even though the serum is negative, continue to have a risk for hepatocellular carcinoma in the long run. Also, people who are immunosuppressed for any reason will reactivate their hepatitis B virus infection. So I think it's very important to follow not only the liver enzymes, but also to do other studies to look at evidence for cirrhosis, whether you like to do a fibroscan or do any one of the other studies to look for evidence of cirrhosis. There should be part of the clinical management of anybody with hepatitis B or C.
Yes, thank you, sir. Thank you so much. And we are getting a lot of comments. Dr. Vivek is MG, thank you. Dr. Soundarya, she's also telling thank you to all the panelists. And over here, so then we'll so it was very interesting session, and maybe I thought it would go on, but because of the paucity of time, we'll have to close it over here. But it was a very exciting session, and a lot of advices to the attendees from your from the excellent panelists, which is an August gathering of panelists, I'll say today. And Dr. N. Kumar Swami sir, Dr. Ishwar Gilada sir, and Dr. Vijay sir, thank you so much for your very passionate, you can say, comments to the panel discussion and advices to the doctors. Thank you very much. And you have brought a lot of clinical pearls for this session. So thank you very much, all of you. And I'll hand over now to Balaji sir for his vote of thanks and comments.
Thank you, Dr. Ketan, and to all the panelists on this evening's session. It was a very healthy discussion, and but for me, what I would say that if I were to sort of summarize the takeaways from this IAS conference that has happened recently, especially the ARV guidelines, I would put this into two baskets: basket A and basket B. The first basket is those that would contain the takeaways that are in our immediate reach. And the second basket would be those items which are possibly like the products which are in phase 2 development, or the long-acting injectables, and all those kind of products which are at the moment of academic interest, but possibly we'll see the light of the day in maybe 2 years down the line. So if you look at the basket A, which is available for our immediate action, implementation, the most significant of WHO. This was something that we had to take it up at WHO level last year, and to bring it to their attention that the world has gone ahead in using more quantity of TAF than TDF, whether it is Europe or US and so on. In fact, the DHHS guidelines, the US DHHS guidelines have been having this TAF in its guidelines for quite some time. So, and this was ably supported by other Indian companies, my representation by other Indian companies, and therefore, perhaps, therefore, we have been seeing the TAF getting equal prominence as TDF. So, as practicing clinicians, need to sort of reflect. The second aspect was the inclusion of the two drug, the dolutegravir, lamivudine, once again in the first line therapy. This again was a product that has always been in the DHHS guidelines for quite some time, but it has gained prominence now in this particular WHO guidelines, which is the basis of a lot of countries adopting it in their national programs. Perhaps this is a watershed moment in the last 40 years of HIV therapy, that a two-drug therapy has come into such prominence, and possibly the future, we are looking at more interesting two-drug options that would possibly come up. So this is another significant thing, and these products are actually available right now with to the medical fraternity. And of course, the third one in the A basket is, I'm talking of the availability of darunavir ritonavir, where it has come into prominence as the preferred PI. And then in the second basket, of course, we have the long-acting injectables like the cabotegravir, the rilpivirines, the lenacapavir. These are all products. Products where it is work in progress. There is developmental work happening by Indian generic manufacturers. And once the developmental works are completed, then we get into regulatory aspects of this. And once that is done, so that we're talking of say possibly 2027 to see the light of the day. But the basket A, as I told you, the three products are very much in the reach of the average physician, the healthcare workers who are operating, and this is something I would say is possibly the take-home message from Kigali conference. So once again, I thank the panelists and Dr. Kumaraswamy for this evening's presentations, discussions, especially the interactions between how the private sector and the public sector would react to these guideline updates. And we at MCure, we assure you that we will have a very healthy platform even going forward to discuss such issues, and we will be in the forefront to bring in more interesting products and discussions as we have always been committed to this cause. So this, on behalf of MCure Pharmaceuticals and the Conquer team, I thank each and every participant and the panelists and Dr. Kumaraswamy for this excellent interactions and presentations this evening. Thank you, and have a good evening.
Thank you. Bye.
Thanks.
Thank you, sir. Thank you.
Bye.
Bye.
Bye, Kumar. Bye, Balaji.
Bye, doctors.
Bye.
Bye. Bye.
Bye-bye.
Bye.
Kumar, it's about